I guess you could look on a larger scale to see if bodybuilders live longer than the rest of us.
Oh,
but
good
I don't
point.
think that study's been done yet. Yeah.
All right, we'll do that one next. Welcome once again to Free Associations from the Boston University School of Public Health, the Public Health and Medical Journal Club podcast for anyone who is confused by the latest health study as I am by clowns. So we are going to be talking about clowns today, and I have to know whether or not you guys find clowns to be scary.
I do.
I do too. Clowns are creepy, but I don't know. Maybe we're not in the majority here.
I fail to understand who likes clowns and why they continue to exist, but we will talk about clowns, and we will see if there's anything positive about clowns. So I am Matt Fox from the Departments of Epidemiology and Global Health at the Boston University School of Public Health, and I am here, as always, with Dr. Chris Gill from the Department of Global Health. Welcome, Chris.
Hello, Matt. How are you?
Doing well. And I am also joined once again by Dr. Jess Lieber from the Department of Environmental Health here at the BU School of Public Health. Welcome, Jess.
Nice to see you both. Nice to be here.
Wonderful to see you again. And a reminder to everyone, if you can go over and head to the Population Health Exchange website at www.pophealthex.org. That's BU's hub for lifelong learning. You'll find lots of really interesting things over there. And also, if you can, give us a rating on iTunes or Stitcher or whatever your podcast app site is. That helps other people find us, and we really appreciate it. So now, on to the show. So today in our first segment, which is our Journal Club segment, we're going to look at a study, in all seriousness, on the effectiveness of clowns for reducing children's experiences of pain. I suppose it's not that crazy an idea, but it just strikes me as strange that it's a study. Then in the second part of the podcast, which is our deep dive, we're going to talk about the ethics of paying people to be vaccinated. And then in our third segment, which is our amazing and amusing, we'll get into some things that make us laugh out loud, or Jess will tell us about frozen poop tools. If you got any updates,
if you're lucky, you'll get that one again.
If we're lucky. So let's get into segment one. So we are going to talk about an article that looked at the effectiveness of clowns on reducing childhood pain. It was published in the BMJ, and it was entitled "The Effectiveness of Hospital Clowns for Symptom Management in Pediatrics: Systematic Review of Randomized and Non-Randomized Controlled Trials" by first author Luis Carlos Lopez Jr. Anyone know how to pronounce?
Junior. I think it's
probably Junior. It's probably
Junior. Okay, yeah. So by first author Luis Carlos Lopez Junior of the Federal University of Espírito Santo in Brazil. A couple of headlines on this one. Forbes says, "Clowns make hospitals less scary for young patients." USnews.com says, "Laughter as medicine, clowns help hospitalized kids cope." Newsmax says, "Study, clowns help hospital kids heal." And Eureka Alert said, "Clowns may help children cope with pain and anxiety from hospital treatment." So Jess, can you start off by telling us what they did in the study and what they found?
Sure. This was an interesting study, and I think, there's elements, in reading about the clowns that is a little goofy, but I think this study is situated in a serious literature, kind of looking at ways to reduce stress and psychological distress and anxiety among children who are experiencing medical procedures. And so just to contextualize this study kind of in the frame of that literature, children who are in the hospital are often without a parent or a trusted adult. And so there is obviously a big interest in pediatric medicine in these intervention techniques to try to reduce stress and promote healing and faster recovery, for example, among children who are in the hospital. So this study is kind of situated in that niche of the literature. And what these authors did, this was a systematic review of studies considering effectiveness of hospital clowns in reducing various psychological symptoms. So symptoms of anxiety, stress, and pain, defined in many different ways, as we'll discuss in a few minutes, among children and adolescents who were admitted to the hospital. So these were children who were inpatient for both acute and chronic conditions, so for many, many different sorts of conditions. So again, this was a systematic review of the published literature. They were looking across all available indexes of published literature for randomized and non-randomized controlled trials on this topic of the effectiveness or intervention studies looking at clowns and children and adolescents' experiences in the hospital. So they had a few kind of focus areas. They were focusing on, as I said, children admitted to the hospital, comparing clowns to the standard of care, which presumably does not involve clowns. So they were drawing studies that were comparing clowns and non-clown intervention. And then again, studies looking at the effects of clowns on symptom management, on clusters of symptoms, so kind of groups of symptoms in inpatient children. What these authors did, which I think is most notable in this analysis, is they used a few different mechanisms for assessing bias, the risk of bias in the studies that they were drawing into their review, which then becomes for us as the reader very important in terms of how we interpret their findings and how they interpret their findings through the paper as well. Kind of what's the quality, what's the risk of bias in the studies that they are using to generate this review paper, and then how do they interpret that? So they used two different scales, the Robbins I scale for non-randomized studies and the ROB2 scale for randomized studies. So I'm not deeply enmeshed in this world of systematic review and meta-analysis, but I assume those of you who are familiar with these tools. But they use these tools to evaluate kind of the risk of bias, and these tools assign a risk score based on different characteristics of the study. Okay, so what they found when they did this analysis, they were able to find 24 studies that made it through their inclusion criteria. They initially identified about 1,600 studies, 24 of which were drawn into their study on the basis of their inclusion criteria. 13 of them were randomized control trials, 11 were non-randomized studies. One of the challenges they found is there was a real variety of the outcome measurements in these studies, included self-reports of stress and anxiety, assessments of kind of facial expressions in young children, which apparently is a tool. And then there were a handful of studies that used biomarkers, for example, of stress response like cortisol before and after the clown intervention to try to analyze stress. But those studies were in the real minority. There obviously is a variety of exposure in terms of really understanding what a clown does. You know, sometimes a clown is juggling. Sometimes a clown is telling jokes. Sometimes a clown is in full makeup, sometimes and the full suit or a goofy wig, or sometimes it's just someone who comes in kind of acting a little silly. So it was very hard to standardize what the exact exposure was across all of these different studies. So right up front, one of the challenges they had was the exposures were varied in the context of 24 studies, and the outcomes were also varied in the context of these 24 studies, which kind of fundamentally made it impossible for them to compare data, kind of generated from these studies. So what the paper kind of morphed into was kind of a narrative review of key points of these 24 papers, which was interesting in and of itself. They also found that most of these studies had either moderate or severe bias concerns. Mm-hmm. So again, that speaks to them not consolidating all of the data and doing a meta-analysis, a statistical approach in this sort of context. But their overall conclusion was that on balance, clowns seemed to be helpful. They seemed to reduce anxiety, help children adjust to complex and stressful psychological situations, have fewer worries, improve well-being and emotional response. There were a few studies that focused on cancer patients in particular. The authors noted that this was an area that had not received a lot of attention, the role of clowns in cancer treatment for children. The authors, towards the end of their discussion section, which I thought was interesting, introduced me to a word called coolrophobia, which means phobia of clowns. And they noted that, they didn't quite know how that might have played in. They did, of their 24, some of them did notice, did not observe a benefit associated with clowns. And so they said maybe clown phobia plays in, maybe there's, clown phobia at a certain age, maybe in the preschool age or younger toddler age ranges where children experience a lot of stranger anxiety anyway. Maybe if you see a clown and the baby's already that would be really bad. Maybe the results are not generalizable to adults who might, as we were saying, might not find clowns always so thrilling. But so there was a lot of narrative discussion in this paper, but overall, they found a positive effect of the clowns.
Overall positive effect of clowning. So before I turn it over to you, Chris, and I want to get your take on what you thought of this particular study, I do want to point out that before and after the clown intervention sounds like the title of either a movie or a book that I would not want to either watch or read. And the second thing I want to say is that the majority of the data from this study, from this review, the majority of the studies came from Italy and Israel, which kind of surprised me. I don't know why exactly. I guess I would have assumed there would be a fair amount of the data from this would have come from the U.S. just because of our population size, and then after that, I don't know where I would have thought it would come from, but
maybe Brazil, given that these guys were all Brazilian researchers.
Yeah, or who, I don't know where. But anyway, Chris, what did you think of this particular study?
Well, Matt, you're always fond of saying, "What was your Bayesian prior?" And
I laugh at that because can I tell you what mine is?
Sure.
Mine was, I wrote down, what in the world?
My Bayesian prior was that this would work, that this should work, that, my experience in hospitals, and I don't have that much experience, of course, in children's hospitals, because I trained in adult medicine, but my experience in hospitals is that they're grim and depressing. Yeah. And sad and scary and impersonal. And the whole idea of trying to bring in, someone to cheer people up and tell a story and maybe juggle and, make people laugh. It's just such an appealingly obvious way of making the whole hospital experience a little bit less grim. It's a distraction. It's a way of bringing in a little bit of life and color. And I was, I felt like, yes, this ought to work in the same way that I think that, bringing around therapeutic dogs to visit patients at their bedside is such a way of relieving stress and bringing back a sense of normalcy. So I was really encouraged to see that the overall results were, even though the source data were not very, rigorous studies, I guess, but in aggregate, they pointed towards, yes, this seems to be a generally good thing, and it kind of makes sense that it would be a good thing. The other thing I wanted to notice in passing was that this was one of the most systematic of systematic reviews I think I've ever read. It really it felt like a textbook example. If I was ever to teach students or attempt to teach students how to do a systematic review, I'd say read this paper, because they've really laid out a map for how you approach each step in the problem. And I thought it was a very meticulous job, impressive in terms of its sort of scholarly rigor. So I was very positive about it. I was, I guess, initially skeptical, but I still felt like this was a good piece of work, and so I wanted to congratulate them.
So you would say this was a pretty serious clown study?
Yeah, I guess. Well, the clowns weren't serious; the clowns were jolly. But yes, that's what I mean.
Okay, so let me back up a little and just say that the way that we do things is we look up, we keep our eye on the literature and then send around studies that we, kind of catch our eye, and then we give feedback on what we think would be interesting. And I was the one who sent this one around, and I was a little surprised that you both reacted positively to this one. I kind of thought this was one that you all would pass on. So I was kind of interested in that. As far as the the rigor of I agree with you, Chris, that the rigor of the meta-analysis or the review was quite high. I mean, they really spent a lot of time and effort in evaluating the quality of these studies and trying to determine what was a good study and what was not for the process of review and for the process of deciding what to put in. The studies themselves, though, of course, were of lower quality because there are all kinds of reasons that you wouldn't be able to do a highly rigorous, even a randomized trial of clowning. For one, you can't blind people as to whether or not they saw a clown. You could blind the data collectors, I suppose, but you can't really, people tend to notice if a clown walks in the room.
Yeah. And you can't use like a placebo clown whose job it is to be depressing and to tell sad stories. I mean, that would be terrible. You could never do that.
Okay.
So there's not really. It's very hard to do a controlled trial around this.
Okay, so I call placebo clown as a band name.
We're sorry the clown couldn't come today. I mean, I suppose you could do it that way, but
well, so no, so you're right, Chris, in that there's sort of no placebo, but you could use what are referred to as attention controls here, where you have, rather than comparing clowning to nothing, which presumably is what the comparison was in most cases, you could compare clowns to, some other form of distraction to see if what really matters is clowning, or if it's just, doing anything that really matters. And anything you can do to distract kids will reduce their pain. And so we don't get much of a sense from this study as to whether or not there is anything really special about clowning in terms of a form of distraction, or whether it's just, one of the many forms that you could use.
Yeah. I suppose that, there's a lot of intangibles, right? About like what is it that brings joy by watching a clown, or really, any performance, any amusing activity, and how do you measure that? So, the authors here approach that question in kind of the reverse, which is that they try to look for evidence of pathology, reduction in pathology, that is to say, did their anxiety levels measured on some scale go down? Did their, sensation of pain improve? Jess mentioned the biomarkers, did cortisol levels fall objectively, suggesting that, there was less activation of their, the sort of fight and flight mechanism, all of those things. But those are kind of unidimensional because they're looking at the adverse effect of the thing that's being treated by the clown, which makes sense. But, and I'm not criticizing the decision to use those as study endpoints. I think those are very logical ones. But I would also just, wonder if one could measure, joy more directly, like how happy does it make, as opposed to like how less anxious are the kids, as opposed to how happy are the kids to see the clown there. And when a child is taken in for anesthesia for surgery and the clown goes in with them and is sort of holding the child's hands and making jokes, I mean, how happy are the children at that moment? How distracted are they? So it just seems that there are so many ways one could look at the effect of the clown beyond what has been done. And again, this is not really a criticism of what they did do, because the results are interpretable, and yet it seems to me that this is in some way scratching the surface.
Yeah, sure.
I was interested also in whether the effects that they observed were due to the clown as a human being interacting with the child in a one-on-one sort of capacity. Like, could that have been a nurse, for example, who's not dressed in a clown costume, but just is with the child and maybe, trying to keep the mood light, or trying to, holding the child's hand, like Chris is saying, or engaging with the child. Did it have to be a clown, or was it just that it was a person who was with the child? And so it's kind of that issue of where does the funniness and the silliness, how does that fit into this whole picture? That was my interesting question. Like, what if it had been a puppy? Like, I don't think you could bring a puppy necessarily into pre-op. Maybe that's the difference, is that some of these other interventions you couldn't bring into these really stressful situations. But how did the clown differ from another person who was not dressed up as a clown? And was there something in the clowning itself, or was it just that it was a person in that environment that helped reduce the child's stress?
Mm-hmm. I was given a book last year for Christmas by one of our research fellows, Lauren Eder. It's Atul Gawande's Being Immortal. It's a really great book, and so I just wanted to say thank you, Lauren. I have enjoyed this book. But there's a very poignant section that's described in the book that I think has many of the same elements of what we're describing, and I think it gets to the point that you're focusing on here, Jess, which is that it's not the clown per se, but it is the humanity, right? The clown is a method for delivering humanity, but it could be a magician. It could be many things. And in this story that Gawande narrates, he describes this sort of young, very talented, recent Harvard Medical School graduate who chooses to go back to his rural home in upstate New York and to eventually take a job as a director of a nursing home. And he describes his arrival here as being sort of astonished because he doesn't really know how to approach the problem, the real problem of the nursing home, which is that, and he describes this in a very beautiful way, I think, which is also somewhat sad, which is that, there are these three plagues of nursing homes: boredom, loneliness, and helplessness. And so what he does is to lobby the owners of this nursing home, the directors, to allow him to bring in animals into the nursing home. And so he gets several dogs and several cats, and he also gets parakeets for every single patient's room in the nursing home. So every person has a bird, and they're supposed to take, to some degree, take care of the bird. But the staff make sure the birds are their cages are cleaned, etc. But the effect of this was really astonishing as he describes it. And there was one vignette where he talks about this man called Mr. L, who had been admitted to this nursing home because his wife had died, and then shortly after his wife died, he was engaged in a very serious car crash that almost killed him. And he was brought into the nursing home as being sort of like, unable to care for himself, and quickly became almost catatonic. He just spiraled down and became depressed and wouldn't interact and wouldn't get out of bed and wouldn't eat and wouldn't do anything, and really looked like he was just heading towards the grave. And then this program began, and they brought the dogs in, they brought the cats in, they brought the parakeets in. And what he described is that the birds particularly drew this man out of his shell, and that he began eating again. He started dressing himself. He started getting out of his room. And then he started volunteering to walk the dogs every day. So he became verbal again and walked the dogs. He took that on as his personal task. And 3 months later, he went home and left the nursing home. I mean, it was just such like an example of the same thing, that we focus so much on the pathology, the reduction of pathology, and yet in many contexts, I think the nursing home is a particularly clear one. We sort of see the problem as being a medical problem, when in fact it might be more, helpful to view it as a humanitarian problem, and that our job is not to simply keep people safe, though that's important, but is also to provide them reasons to live.
Yeah, I think those are really good points, Chris, and I think we clearly don't pay enough attention to some of the emotional and mental health issues that go along with, or that determine health in many cases. So I think you're absolutely right. I do wonder, Chris, I mean, to that point, does it matter at all that these are subjective outcomes? The outcome of you say, you could do happiness, or in this case, just reduction of stress. These are subjective outcomes which are potentially influenced by the just, seeing knowing that something is being done. On the other hand, maybe that's the point, and therefore you don't care that this is a subjective outcome that is susceptible to being influenced by knowing that you're getting the intervention. So I'm unclear on whether or not it matters here.
Yeah, I guess I feel the same as you, because in a sense we are, I think all three of us in our research careers tend to focus on very categorical endpoints. I mean, you for example, you are interested in how well patients are retained in HIV treatments, according to different models. And so that endpoint is very clear. And I focus on child survival and infectious rates. And so do you have respiratory syncytial virus or don't you? It's clear. And Jess, you're in environmental health. And so you have a set of exposures, presumably, that you're looking at that either exist or don't exist and lead to a health outcome or don't. And here we are dealing with this sort of social and I guess somewhat gray area, difficult to pin down, difficult to categorize, and yet, obviously based on our shared experience as humans, is one of the most important things there is about life, which is not just to live, but to be free of pain, to be free of fear and sadness, to have joy. And those are constructs that are not generally seen much in the medical literature. And I suppose it's a shame.
I think they're fundamentally the hardest to measure. I mean, that's that's part of what's so interesting about this paper is that, there's all these challenges with like, how do you measure what a clown is doing? And then how do you measure the effect of that clown, of the benefit or the drawback of that clown exposure? And it's really complicated when it has to do with happiness, or like you're saying, when it has to do with well-being or comfort, especially if the immediate, maybe there's a longer term benefit. And maybe it's a 15 minutes with a clown in the hospital room relates to a child recovering 2 weeks sooner from a procedure. Maybe there's a lag effect between the exposure and the outcome. So I think it's really hard. These are really important. I think you're exactly right. It's like, how do you measure human connection? And then how do you measure the effect of human connection?
And so given how important that, this seems to be, are you at all surprised by how little data there actually is? Because these are, in some sense, you can understand why there haven't been a lot of studies done, because it's probably not something people are paying a lot of attention to trying to evaluate. It's just something you do or you don't do, and you don't spend a lot of time. On the other hand, it's been around for a long time. And so in some sense, I was a little surprised there wasn't more data.
I had wondered actually if clowning seems pretty inexpensive in a hospital, for example, that maybe clowns are one of the less expensive interventions to bring a little bit of humanity into the hospital. Obviously it would be more expensive if if a nurse was assigned to a child who was going through a difficult procedure, and the nurse, was going to get to know the child before the procedure for a certain amount of time, and then stay with them in a concerted way and kind of bring some entertainment. And, I think nurses do this anyway, but I think it would be I think other interventions might be more expensive and more time consuming. And so my sense with clowning is it's almost like, what's the harm, right? Like you might as well just do it without analyzing it, because is there really a drawback to bringing in a fairly inexpensive intervention? That was kind of my take on it.
Unless, of course, like me, there are kids who are freaked out by clowns.
Right. And there were. In these studies, there were kids who were freaked out by the clowns. And the authors talk about a study that was not in their analysis, but another study where they just kind of, what's the prevalence of being afraid of clowns? And it was like 80 some odd % of girls, for example, were afraid of clowns at certain ages. And there was an age effect and a gender effect. And so it's certainly not unusual for children to be afraid of clowns. And I think the authors were aware of that.
Okay, well, we can move on, but before we do, I just want to comment on a couple of last things before we do. One is that I really enjoyed that they paid a lot of attention to how they defined a clown, which they spent a lot of time going through, and they note, and I sort of vaguely remember this from the movie, but they say the American physician Patch Adams started clowning for patients in the mid-1970s and was considered a pioneer in therapeutic clowning. And I remember the movie Patch Adams from, I don't know, was that the 80s or 90s? But
Robin Williams, right?
With Robin Williams, yeah, which I sort of didn't even think about when this paper came up. The second thing is they spent a lot of time in this paper talking about how they would go about disseminating their results. So clowning websites with, going to troops and which I just thought was interesting, because you don't normally see that in scientific papers, particularly in, the top medical journals. Okay, let's move on to our second segment. So in our second segment, we're going to talk about a paper on the ethics of paying for vaccination. We're in the middle of the rollout of the COVID vaccine, or I suppose we're at the beginning of the rollout of the COVID vaccines. And this discussion is motivated by a comment in JAMA by Emily Largent and Frank Miller. And the title of it was Problems with Paying People to be Vaccinated Against COVID-19. Now, I set this up as ethical issues, but it's really probably just issues in general. So they start off by noting that obviously we're going to need a lot of people to get vaccinated with the COVID-19 vaccines in order to get to the point of herd immunity. And we know that there is vaccine hesitancy out there, that there are a lot of people who are saying, at least in the US, that they won't get vaccinated. Seems like the biggest predictor of not wanting to get a vaccine here in the United States is identifying as a Republican, which I thought was an interesting fact. So there have been a couple of different proposals for ways that we could increase the incentives for getting a vaccine, some of which have been proposals to actually pay people to get vaccinated. So one proposal was to pay people $200 initially and then condition a remaining $800 on reaching some kind of a national vaccine uptake level. So everyone gets $200 when you get your shots, but then if we as a country get to the, say 70% threshold that we need for herd immunity, then everybody would get an additional $800. Another approach would be to just pay people, what proposal was $1,500 via check or direct deposit. So you just get the money for getting vaccinated. They say there are problems with this approach. So the benefits, of course, would be that presumably you would incentivize people to want to get the vaccine, even if they may not have wanted to already. But they say, people have a moral duty to be vaccinated. And so paying them for something that they have a moral duty to do is not something that we should be doing. Second, they say it's not a particularly prudent investment because many people are going to get vaccinated anyway. So spending money that you wouldn't have to spend in order to get people to do something that you want them, many of them would do anyway, is not a good use of financial resources, particularly in a time when we are constrained financially with the interventions that we need to do because of the lockdowns and things like that. They suggest this idea that people are saying that paying people money is as an incentive is coercive. They point out that is incorrect, that it is not coercive, but that it may be seen as taking advantage of people who have lost their jobs, who are in poverty, or who may be disadvantaged. And finally, they noted that the vaccine hesitancy concerns are rooted largely in the speed of the development. And so it's not clear that offering a financial incentive would overcome those concerns. And so I'm really curious your thoughts on whether you all think that this is something that we should be doing. Jess, I'll start with you. How do you react to the idea of paying people to get vaccinated?
I lean towards not paying people to get vaccinated for a few reasons. I mean, one, there is, I'm not exactly sure the word I'm thinking of, but there is kind of an authoritarian structure to that. It reminds me of something that is done like in an elementary school classroom, especially the idea of where, if everyone behaves and is quiet during math period, then the whole class gets extra recess, right? Mm-hmm. It's kind of like the idea, that sort of structure to me strikes me as condescending is the word I was thinking about. That, kind of a condescending approach towards people's ability to make a decision with their own free will. I think as a public health or medical community, we have an onus to engage in that conversation and try to encourage people to move in the direction we think is in the best interest of public health, which would be to get vaccinated. However, I think the idea of putting money behind it feels a little bit inappropriate to me. I think because it feels a little authoritarian in that same sort of way, like a teacher-student sort of dynamic. The other idea that I thought was really interesting from this piece was their first comment about the moral imperative of getting vaccinated and that being an important component in public health interventions and not wanting to diminish that. And I thought that was actually an important thing to think about that I hadn't thought about before, that we don't pay people to get other vaccinations. We don't pay people to engage in other behaviors that are good for public health more generally. And if we set that, if we kind of set the example right here now, does that mean that then people will be expected to be paid to get the flu shot, for example, or they expect to be paid to have their kids fully vaccinated? And what are the downstream consequences of putting a monetary incentive into some of these behaviors when maybe our better role as public health folks is to engage in the discussion and to kind of be part of that larger dialogue as people make their decision, yes or no.
Okay, Chris, how do you react to the idea?
Well, it's interesting. I reacted negatively and then positively and then negatively as I read the paper. So I found that my opinion kept shifting, and I think it was shifting because I kept thinking of some things that I disagreed with that the author had said, which I think were not correct, but also trying to sort of extrapolate this idea to other contexts. So in terms of the thing I disagreed with them is that they're saying we've got more than 75% of the population needs to be vaccinated for the country to achieve herd immunity, and that is obviously false, right? The herd immunity calculation is based on the number of people who are immune, not vaccinated, because vaccinated doesn't necessarily leave you to be immune. Mostly it does, but there are other ways to become immune, such as being infected with COVID-19 and recovering. So both of those contribute to herd immunity. So that is categorically false. But the thing that kind of stuck on in me, and you mentioned it in reference to influenza vaccines, is it's basically how much risk are we willing to absorb, or how safe do we wish to be? Because influenza, as I think you were alluding to, kills a lot of people every year, right? And we don't shut down society for influenza. Influenza kills in a bad year 50,000 U.S. citizens, and in a good year 10,000 citizens. That's a lot of people, right? So compared with COVID-19, it's a very small number, but it is a number. And so are we does our risk tolerance for COVID-19 continue once a sufficiently high number of people have been either immunized and are now immune, or have experienced COVID and have recovered, such that the actual mortality rate for COVID-19 in the future is something more akin to what we see with the seasonal flu. And at that point, do we adapt our risk profile in response, or do we somehow see this disease as being distinct, and therefore our risk tolerance must be much, much lower? And I don't see any reason why that should be so. So, I felt like there was a premise that the argument stemmed from that I think was a little bit too simplistic.
When you say that, you mean the argument for paying people?
Yes, that it starts with the assumption. It starts with the assumption that we have to have, basically perfect protection against COVID-19. We've got to completely shut it down. And while obviously that is the ideal, it is also true that as one approaches that threshold for herd immunity, you're seeing disease transmission rates and hence mortality rates drop until they start to the epidemic starts to mathematically extinguish itself. But it's not that things are terrible, and then when you hit herd immunity, things are great. That's not how it works. It's a transition, right? So somewhere in that transition, we have changed the risk profile of this disease to varying extents, and at some point, the risk profile essentially starts to fall to zero. But does it need to fall to zero before society can resume? And obviously, that is not the case, because there are many infectious diseases that are endemic in our society that we tolerate, and they kill people every year, and not everybody has to wear a mask at all times because of the influenza. Maybe we should, but as a society, we have not felt that was an imperative, right?
Mm-hmm. Mm-hmm. Okay, so I'm going to take the other side. I think this is a good idea, and my reasoning for this is in two directions. Number one is that I think we pay people to do things all the time, behaviors that we want people to engage in through, we may not pay them directly by depositing a money into their bank account, but we do it through financial incentives, typically through tax breaks. So if we want people to buy homes, or, then we have tax breaks around to make it more desirable to people financially to invest in a home, or we want people to go out and buy hybrid cars or battery operated cars or solar power. We make it financially advantageous to them to do those things that we want them to do. And this is a case where we have resistance to something that we think is a good thing for the entirety of the society. And so we pay people. It does not require anybody to do it, but it provides more of an incentive to do something that we think is important for everyone. The second reason that I think it's a good idea is, Chris, your point is absolutely right. On the other hand, we are theoretically in a race here against time, and it's not just a race to get the U.S. population vaccinated, it's a race to get the world vaccinated, because in theory, if mutations in the virus develop such that they become resistant to the vaccine, then we are back in a place where we've got to sort of start over again, and we could end up with, high mortality. Now, I'm not saying that's a likely scenario, but I'm saying it is a theoretical possibility. And so if a large segment of the population chooses not to get vaccinated, those of us who feel it's important to get vaccinated are potentially in a position where we're back to square one. So I just see it as, I don't have a moral concern about paying people to do things that we think are good for society. And I think this is a case where it makes a lot of sense.
Mm-hmm. Mm-hmm.
I would add, I think I've been thinking in my mind, kind of, you're certainly correct that there are things that we encourage financially in society that we view as towards the public good, to the extent that we put money behind it as a society. You're saying purchasing homes, or I'm thinking about environmental regulation, for example. There's incentives that companies face to reduce emissions, or to, whatever it is, for environmental protections. And I wonder if there's a fundamental distinction between something having to do with your, like, as a medical intervention, versus something you might buy, or some sort of externality you might admit as a company, for example. Is there something different about society saying, if you get a shot, something that's going into your body that's affecting your medical care, is that distinct from saying we want to encourage, we're going to put a tax on on sodas, for example, which is also something that could go into your body, or there's some sort of other tax on a public behavior? Is it different if it's a medical intervention? And also, is it different in a moment of pandemic compared to not a moment of pandemic? Like, do we have a different structure for these decisions right now because we're living in this crisis moment? If we were not in this crisis moment, would we view it differently? And does that matter? Does that matter if we would view this decision differently if we were not in a crisis moment?
I think yes. The answer is yes. It is different because it's a medical intervention. I do agree with that. And I think that does alter the calculation, but for me, it doesn't alter it enough to make it something that we wouldn't want to do. And I would also say yes to your second point, if I could remember what your second point was, but I know that I thought it was a yes. What was your second point?
Does the crisis change our moral calculation?
Yeah,
right.
Again, I think it does. I think we are not going to pay people to get influenza vaccines. And yes, it is theoretically possible in my mind that if we pay people to get the COVID vaccine and then we don't pay them to get the influenza vaccine, that influenza vaccine rates could drop. But, we do this all the time. We worry about, risk compensation, and they rarely happen. Go ahead, Chris.
Let me ask you a question to restate the context. Mm-hmm. So right now there's a lot of concern about vaccine hesitancy, which is, the genesis for this paper.
Yep.
So, at some point, right, we will see that society partitions into those who have been vaccinated and are now protected, and those who have refused to be vaccinated and are continuing to be at risk, but now they are increasingly at risk to themselves. Within the group of, that is to say, vaccine refusers, they are now exposing other vaccine refusers because the vaccine acceptors have all been vaccinated.
Yep.
So the risk that I think we were so focused on at the beginning was that the refusers are putting the acceptors at risk, and that was true, but that will become less and less true. So at the point when they start to become more risk really unto themselves, does that change the way society feels about trying to encourage them to change their position? Or do we just say, you've made your decision and you are now responsible for the consequences of your actions?
Yeah, I mean, I think you're right, Chris. If this didn't have any potential repercussions for those who are getting vaccinated, I think that might be true. I just think we don't know that yet. We don't know whether continuing to allow the virus to circulate in, fairly unchecked within a subset of society, because as you point out, these, people who don't get the vaccine tend to congregate together. And so you'll have continued transmission for a while within subpopulations.
And then they will eventually become immune, by the way, or perish.
True. But again, it's, it's going to move a little bit slower because there's just, fewer total people infected. And if that leads to resistance that affects everyone, then it's a problem. If it doesn't, then I would agree with you.
Mm-hmm, mm-hmm. And I suppose that there's a spectrum here. There's a gradient of scenarios where we would want to be, to provide this incentive, or maybe gradations of the incentive. If you were someone who works in a nursing home, for example, I think that it might not be an issue of an incentive. It might be a requirement for your employment that you get the vaccine, because you're exposing highly vulnerable people to this potentially deadly disease. And so I sort of feel like that's an example where there is no, there are very few exceptions to accepting the vaccine. And on the other end of the spectrum, you think, what about people who live in a rural area, who have very low, very small social networks, and are very unlikely to transmit or be exposed because of their their isolation, and they may also be hale and hearty and unlikely to to experience a very severe consequence if they are infected. So it's not an all or nothing. Right?
Yep.
The complicating factor here is that we all exist in this web of interactions. And of course, COVID-19 spreads from person to person to person to person to person. That's how it moves. And so each person who is infected has the potential to, perpetuate a chain of transmission that eventually leads to someone who's vulnerable. That's the main concern.
Yep. Jess, any last thoughts before we move on?
I thought one of their more interesting comments was in their last point at the article about whether or not paying people would increase vaccine hesitancy, because the implication behind it would be, we understand that this is risky, right?
Yeah,
we understand that you don't want to do it. I was interested in that too, that they made that comment that it's quite possible that putting a dollar value behind getting vaccinated is an acknowledgement that hesitancy is legitimate in this context, and you have a reason to be concerned, and whether or not, and the authors made the point that could even worsen vaccine hesitancy for some people who are maybe considering it, and they're like, well, now I'm definitely not going to get it, because the implication is that this is that I have to be paid to take it. So I thought that was an interesting argument as well, and not one that I had heard before in this discussion.
And I would agree. I mean, I do think that is a real, it is theoretically a possibility. I don't know that it overcomes my feelings that we should try something like this, but I do acknowledge that it is potentially a possibility.
I would prefer that the incentive be, really targeted at, allowing people to engage in certain behaviors again, such as, you can go to a bar. You can go in an indoor dining area and have a nice meal, but you've got to be vaccinated in order to do that.
Yep, that's another way to do it.
If now we're not saying, here's $500 if you get a vaccine. We're saying now you can go back to doing things that you enjoy in your life, and we consider you to be zero risk to yourself and to others, and so here is your reward. Society suddenly opened up to you. That seems like a much better incentive in some ways.
Yep. There would be certainly a different approach to the same idea. Yep. All right, let's move on to our last segment, which is our amazing and amusing. And Jess, you wanna go first this time?
Sure. So carrying on in my thematic discussions about animal research, this one's a little bit different. This was a study that was published about a year ago that I admittedly thought of because I have a daughter in 5th grade who's reading the book Tuck Everlasting. I don't know if either of you read that one.
Oh, I saw the movie.
I never read it.
Yeah, right, about living forever and what are the consequences of living forever. And so there was this study that came out last year that was looking at this dietary supplement that bodybuilders take. It's called AKG, alpha ketoglutarate. And so, some toxicologists said, let's give it to mice and let's give it to worms and let's see what happens. And what they found is that it extended their life dramatically. And specifically in worms, they say, let's see, it was found that it extended the lifespan by more than 50% in a tiny worm with a long name that is too long for me to read. And they also found a similar effect in the study of mice, that they found this life extending virtue in this dietary supplement that it seems like is available over the counter. And what the researchers have said is that it's part of the metabolic cycle that transitions food into energy on the cellular process. They didn't go into great detail, at least in the blurb that I was reading, about what the science is behind it. But I thought that was interesting. This is, not something we're hearing too much about in the time of COVID, about medications that could extend your life, and not to say that we would want to move down the path of life-extending medication or even thinking in that direction. But I think in the last number of years, there's been a tremendous focus on gene editing, and kind of gene editing as a mechanism to improving quality of life and to improving treatment efficacy, and then, generation of babies through CRISPR, and like all of these debates in our scientific literature. And I haven't seen very much about just like life extending medicine. So I was intrigued. I was just intrigued by this study.
Very interesting. Okay, I will go out and start taking it immediately.
I guess you could look on a larger scale to see if bodybuilders live longer than the rest of us.
Oh,
but
good
I don't
point.
think that study's been done yet. Yeah.
All right, we'll do that one next. All right, Chris, what do you got for us?
Well, it's funny that you should mention the I guess the nematodes, right? There was a story I was thinking about talking about, that there are two articles that I spotted in the New York Times that both sort of tickled my interest. One of them was about how certain roundworms seem to be able to detect ultraviolet light and move away from it, even though they don't have any eyes. And so that there were cellular receptors on the nematodes that allowed them to sort of sense this exposure to radiation in some way that, utilized a totally different cellular pathway other than like the ability to see per se. So, but I couldn't figure out a way of spinning that into a longer narrative. So instead, I came across another story in the New York Times, which actually was even more fascinating. That is a shout out to the Boston University people who study astrophysics. They published this fascinating paper recently about this event that happens on a regular basis where the moon generates a beam of sodium ions that fires out like a laser from the backside of the United States of the world. Excuse me. And the way this works is that the moon is constantly being hit by meteors, I guess, that they become meteorites after they've hit. So the moon is being pulverized, and each time it's struck, it causes a little cloud of dust to fly up into it's not the atmosphere because there's no atmosphere, but it flies up into, away from the surface of the moon. And because these particles are very small, they can stay there suspended for a very long time. And so these particles are basically the moon is surrounded by this sort of invisible sphere of sodium ions. And these sodium ions get sucked up by the Earth's gravity and pulled towards the Earth, and then they stream around the Earth, sort of forming a halo. Now, at the same time, the moon is going around the Earth, and so it's directing this beam of sodium ions in different ways. And at the point where the moon and the Earth align exactly so that their gravitational fields are perfectly aligned, these sodium ion fields that have been transferred from the moon to the Earth then eject out the far side of the Earth in a more or less straight line like a laser. And with special equipment, you can see this. And of course, we can't see this, but the thought of this is just so fascinating that unbeknownst to us, our planet is basically firing out this beam of high energy particles into space. Kind of like, it's like we're picking up the comet's tail, but here the comet is the moon. And, the stream of sodium particles that are being driven off the moon towards us are being driven by photons from the sun. So it's like, the moon really is literally acting like a comet, where the tail of these sodium ions is being driven constantly away from the direction of the sun's light. And when it hits the Earth, and at just that right moment where the beams and the gravitational fields of light, you get this blast like a laser of sodium ions off into space. And the thought of that just like shocked my world.
Very cool. This is not something I've ever heard anything about.
Yeah, I mean, I wish you could go to the far side and watch it, but you can't.
No,
because there's nothing to see. But if you had like a sodium photometer, I don't know what it would be called.
Sodiometer?
A sodiometer, right? This is the best thing that happened to dinners. It's salt. Anyway,
Okay.
that's what I wanted to talk about.
Very cool. Very cool. All right. Well, for mine, I am going back to the International Journal of Epidemiology from an article from 2014. This was an article published. The first author was Neil Pierce, who those of us in the epidemiology world know Neil well. And the study, I found out about it because he tweeted it when I asked the question, what is the piece of work that you have done in your career that you are most proud of? And he tweeted back this study to me. The title of the study is the ICALE collaboration, randomized trials of beer recognition.
Ooh.
So this is a study that I enjoyed for two main reasons. Number one, it begins with a Frank Zappa quote, which is, to be a country, you need to have a national airline and a national beer. And they begin by pointing out that Tonga no longer has a national airline, but that they do have two national beers, ICALE and Royal. Both are lagers, and they presumably were on a trip there as part of some research they were doing, and decided that they were going to do essentially a crossover study, essentially like a taste test type, blinded taste test type study of these two different beers to see if people could tell these different beers apart. I'll just cut to the chase on it, which is that they could not. There was no, the guessing which beer was which did not differ from the null hypothesis of, you'd expect 50% of the time you'd be right just by chance. So that is not particularly surprising, given that I find most lagers taste exactly the same, at least to me. Apologize to all the lager lovers out there. But the second reason I wanted to bring this study up was because, Chris, it reminded me so much of your study that you did, which was a study of the comparison between Marmite and Vegemite,
Yes.
which I would like you to describe for people.
Seminal research.
Can you describe it?
Well, the thing or the study? I guess I suppose I can study the both. So Marmite, for those who are not in the know, the privileged cognoscenti, is a concentrated yeast extract that is the derivative of brewing beer, I think, which is where Matt was coming from. It's the sponge that's basically left on the inside of the pot. And normal people would probably clean it off and throw it away.
Yes,
or if you're a clever marketer, you could scrape it off and sell it and add some salt and say it is a healthy treat, which is what has happened in much of the British Commonwealth. And I grew up eating Marmite, and I love Marmite. Now, there is another version of this stuff. There are several versions, actually, but the competitor version is Vegemite. If you remember the Men at Work song from the 1980s, they talk about he gave me a Vegemite sandwich. So Vegemite is a vastly inferior product that tastes like pond scum and should be avoided at all costs. And to demonstrate this empiric fact, a friend of mine who's from Australia and actually mysteriously had differed in his interpretation of which was better, Marmite or Vegemite, did a small blinded taste test amongst the members of our department where we presented them little bread and butter squares with either Vegemite or Marmite, and we had people rank their level of deliciousness. And it was really interesting because most of the participants, I think, were from America and were brand new to this whole concept of yeast extract on toast. And curiously, the reactions were decidedly negative. I was fascinated by this because it seems like everybody loves Marmite. It's an empiric, obviously. It's like a maxim. It's a truth. It's a universal truth. And yet somehow we had stumbled into this small minority of Marmite and Vegemite exemptors. It was hard to explain. Anyway, we published the results, and the p-value was above 0.05. But we should not focus on p-values.
What journal did you publish that in again?
The Journal of Irreproducible Results.
Well done. Yeah. Well done.
Our finest paper ever, I believe.
Yeah, so I think it goes in that same category, which is why. So it made me think of your study, both in that it was a crossover-y type, taste testy type study amongst a small group of researchers, most of whom probably did not receive proper informed consent. And no, you did in your case. I remember we had to give blood samples, didn't we?
Yes, and a biopsy.
Yeah. Yep. Anyway, so I thought it just reminded me of your study. So that is the end of our program. If you got any feedback on this or any other episode, or if you want to suggest a study or a topic for us to take on, you can tweet us at PopHealthDX, or you can tweet me at Prof. Matt Fox or Chris at ID.Gill, or you can find us on the Population Health Exchange website at www.pophealthdx.org. We want to thank Leslie Talalian, Assistant Dean of Lifelong Learning at the BU School of Public Health, for supporting the podcast, and Nick Guler for sound editing and troubleshooting all of our broken computers. Thanks for joining us. We hope you enjoyed it, and we hope you will download our next episode.